Hello everyone. This presentation will be about vomiting in children. The slides are made by the Indian Academy of Pediatrics and are available online as a part of the 2015 to 2016 teaching modules. Now, the first point which I would like to emphasize at the start of this presentation is that vomiting is a symptom and is not an illness in its own. It is not a diagnosis. Vomiting is a complaint. And vomiting is associated with three linked activities, namely nausea, retching, and the active expulsion of the stomach contents. By definition, vomiting is the oral expulsion as a result of the retrograde expulsion of gastric contents. Nausea is defined as a subjective feeling of a need to vomit. In general terms, nausea precedes vomiting. Regurgitation is the effortless expulsion of gastric contents, and rumination is the repeated regurgitation, which is usually because of rechewing and swallowing. Now, coming to the physiology of vomiting, before coming to the topic per se, we know that there are two centers in the brain. One is the CTZ, which is the chemoreceptor trigger zone, and the central vomiting center. Now, the CTZ is a set of bilateral neurons in the brainstem underneath the floor of the fourth ventricle. This functions as chemoreceptors and hence the name, as a result of which the chemical abnormalities are detected. Central vomiting center is situated in the reticular formation. It receives signals from outside the CTZ based on visceral efferents from the GIT, as well as from outside the GIT from various regions such as the bile duct, peritoneum, heart, and from extramedullary centers in the brain. Now, the physiology of vomiting as such has three phases: the pre-ejection phase, retching, and the ejection phase. Now, before going into that, we'll understand the normal physiology of swallowing, what happens. Now, we will assume that there is an oral cavity, an esophagus, a stomach. The lower esophageal sphincter separates the esophagus from the stomach, which will be highlighted in blue. What you see in blue is the lower esophageal sphincter, and the second blue part, which is 1, this is 2. 2 is the pyloric sphincter. 2 separates the stomach from the duodenum, first part, and 1 separates the esophagus from the stomach. Now, what you see in green will be normally what happens. When food is eaten, it is chewed in the buccal cavity. Based on deglutition and swallowing activity, it happens through the esophagus, comes into the stomach. Within the stomach, the churning and basic digestion occurs. Subsequently, further digestion occurs through the second part, through the second sphincter into the first part of the duodenum. Now, it is important what I am highlighting here. The lower esophageal sphincter is a physiological sphincter. There is no physical sphincter as such. It acts mainly based on a physiological action, whereas a pyloric sphincter is an anatomical sphincter. When I say anatomical sphincter, there is an actual sphincter which is present, which prevents the contents from going into the duodenum. That is the first point to highlight. The second point is the importance of this lower esophageal sphincter, what I am drawing here. The importance of this is because the stomach pH is generally less than 1 to 2. And the epithelium is specialized within the stomach to prevent the damage to the stomach mucosa, whereas the esophageal mucosa, which I am highlighting here, is weak and is susceptible to pH changes as a result of the gastric aspiration. Now, coming back to the topic per se, we have three phases: the pre-ejection phase, which is characterized by nausea, increased sympathetic as well as parasympathetic activity, and it is associated with increased salivation, tachycardia, and deep breathing because of the gastric relaxation. Retching is characterized by the rhythmic action of respiratory and abdominal muscles, and the ejection phase is characterized by intense contraction of the abdominal muscles and relaxation of the esophageal sphincters. Now, coming to the diagrammatic expression of this, the same way you have the oral cavity, the esophagus, the stomach, and the first part with the sphincters. The first and foremost action to happen is a relaxation of the physiological lower esophageal sphincter. So once the food is present, the normal motion will be from here through the pyloric sphincter into the duodenum. But due to the retrograde propulsion, it comes outward. So it comes outward, and as a result of the retching, it gets vomited out. Now, we'll classify the causes of vomiting into neonatal, infancy, childhood. So To come to the causes of vomiting in neonates, we can further classify it into gastrointestinal causes and other causes. Now, gastrointestinal causes is the most common, whereas there are other causes too. I would like to mention that vomiting is predominantly a gastrointestinal complaint, but vomiting can be suggestive of other systemic involvement also. The gastrointestinal causes of vomiting in neonates could be swallowed but because of a cracked nipple, faulty feeding technique and poor burping, gastroesophageal reflux, gastrointestinal anomalies such as atresia, stenosis, malrotation and volvulus. These are surgical conditions and somewhat rare. Other non-gastrointestinal causes include systemic infection like sepsis, birth asphyxia, hydrocephalus and inborn errors of metabolism of various metabolic errors of proteins, carbohydrates, etc. Coming to the causes of vomiting in infancy, again we classify it into gastrointestinal and other causes. The gastrointestinal causes include gastroesophageal reflux, gastroenteritis, pyloric stenosis. Now this is important cause. Intussusception, which is seen classically in the weaning age group, peritonitis, malrotation and volvulus. If we see other systemic causes of vomiting in infancy, it is CNS infections such as meningitis, intracranial space occupying lesions if affecting the vomiting center, hydrocephalus, uremia, faulty feeding and overfeeding as well. Now moving on to the child age group, generally in this age group we tend to see gastrointestinal causes taking a predominance. Gastroenteritis is the most common cause in this age group, in a child age group. AGE is the most common cause of vomiting, followed by gastroesophageal reflux disease and other surgical conditions like intestinal obstruction, intussusception. Now, it is important to note UTI, though it is mentioned here under gastrointestinal cause, it is a systemic cause along with other causes such as appendicitis, hepatitis, peritonitis, etc. Now, other somewhat more rare causes could be CNS infections. Like I said, meningitis can also present with vomiting, intracranial space occupying lesions, diabetic ketoacidosis, which is an acute emergency, metabolic emergency, toxins poisoning as well as psychogenic habitual vomiting are all causes. So we have seen the classification of vomiting and causes age-wise. Now, if you approach a child with vomiting in an office practice OP setup, I'd like to emphasize that vomiting is the second most common complaint with which children are brought to the OP. The first most common, of course, is fever. So the first most common complaint is fever and the second is vomiting. So moving on with that, as with any history and examination, we need to know history-wise what is the duration of the vomit, what is the frequency at which the vomit has happened and the type of vomit. It is important to note whether it was food particles, which could be because of a gastroenteritis, whether it was fluid, whether it was blood tinged, bile stained or whether it contained a fecal matter. Presence of fecal matter is suggestive of a surgical emergency. Presence of bile can be suggestive of pyloric stenosis. Presence of blood is suggestive of blood ingestion, or it could be suggestive of an ulcer, whereas presence of food is most common. The smell which is present in the vomitus is important to rule out the presence of poisons or toxins. And it is important to ask whether the complaint had a history of nausea or not, and whether it was projectile or non-projectile. Now, this becomes important to identify whether it is a CNS cause or not. So, to understand that, we should know the meaning of projectile or non-projectile. We will assume that this is the child who has vomited, and I am highlighting the vomitus in this yellowish color. So, when the child vomits, if projectile, it will be with a force and will fall away. Whereas if it is non-projectile, it will fall towards the child and the clothing will get stained. 1 and 2. What you saw 1 was projectile and what you saw 2 is non-projectile vomiting. Now, projectile vomiting is generally seen in a CNS cause, and associated without nausea is also a CNS cause. Whereas non-projectile with nausea is generally a gastrointestinal cause of vomiting. I've specifically highlighted with the 2 colors. Projectile vomiting without nausea is a CNS cause, and non-projectile vomiting with nausea is a gastrointestinal cause of vomiting. Now, like I mentioned, vomiting is a complaint and is often associated with other complaints. The other complaints to be asked include loose stools, fever, respiratory distress, color of urine, whether presence of cough is there or not, the presence of other complaints such as abdominal pain or headache. Headache is with vomiting is always suggestive of a CNS cause of vomiting. Presence of loose stools with vomiting can be suggestive of a gastroenteritis. Presence of fever with vomiting can also be a part of gastroenteritis, and respiratory distress associated with vomiting can be a pneumonia with secondary vomiting as a result of post-tussive. Cough also goes in the same favor, whereas a high colored urine is suggestive more of a UTI. Now, on examination to a child who has vomited, we must observe for signs of dehydration, signs of acidosis, any electrolyte imbalance, check the vitals, check the level of consciousness and the nutritional status of the child. Apart from that, a detailed evaluation of all systems is a must starting from per abdomen. Now, the consequences of this can include dehydration, electrolyte imbalance, acid-base imbalance, hypovolemia shock, malnutrition and aspiration as a result of vomiting. Before going into that, the investigations to be done for a child who has vomiting, if sick enough to warrant an admission for rehydration based on IV fluids, it is important to check a baseline CBC as well as serum electrolytes apart from a urine routine. Now, the importance of serum electrolytes is as a result of vomiting, there should not be an electrolyte imbalance. Now, dehydration is the most common consequence which is associated, and in the presence of dehydration, it is to be corrected and assessed clinically whether it falls under some dehydration or severe dehydration and corrected accordingly. If an electrolyte imbalance is found, it is to be corrected. If the child is malnourished, if it falls under an acute malnutrition, to be treated accordingly. If it is a chronic malnutrition, to be stabilized and then correction measures to be initiated. Now, in specific conditions, if you see, gastroenteritis is where vomiting is followed by loose stools. An intestinal obstruction is where vomiting is associated with constipation and distension of the abdomen, and vomiting will be projectile in nature. And bleeding per rectum is seen in intussusception. If you see central nervous system causes, like I mentioned, there will be association of headache, and vomiting is projectile in nature with early morning headaches. Coming to the treatment, generally it is not required if it is a single episode and there is no specific cause. A single episode does not require any treatment, and because vomiting is a protective mechanism. What is important is to identify the etiology, to identify the cause and treat the cause accordingly. First aid home management is to give sips of fluid so that the child does not vomit further, and antiemetics such as ondansetron are reserved for very few specific conditions such as vomiting due to chemotherapy, motion sickness or diarrheal disorders with frequent vomiting where it interferes with oral fluid therapy. However, on a practical basis, it is not always feasible to ensure that. So, when the parents bring the child for the first time, generally reassurance will do the trick if we reassure them confidently and inspire confidence to the parents. However, generally they do prefer to have an antiemetic to be started for their satisfaction and for medical legal safety as well to us. So, generally what we do give is ondansetron, which is also sold under the trade name of Emicet. Now, Emicet is available in two different forms. One is the syrup and one is of course a tablet. So, the tablet Emicet is available as 4 mg and the syrup is available as 2 mg per 5 ml as well as 4 mg per 5 ml syrups. And the dosage of Emicet to be given in children is 0.15 mg per kg per dose. So, the dosage of Emicet to be given is 0.15 mg per kg per dose, and it is available in different formulations, namely syrup and tablet. Tablet is available as 4 mg and syrup is available as 2 mg per 5 ml and 4 mg per 5 ml syrups. Now, based on this example, if we want to calculate for a 10 kg child, for a 10 kg child the requirement is 10 into 0.15, which is 1.5 mg. So 1.5 mg, if it's to be given, 1.5 mg is best given as 3.5 ml of 2.5, 3.5 ml of 2 mg per 5 ml syrup. So that is just a rough example to calculate as an example for a 10 kg child present with vomiting. And like I mentioned, it is better to reserve Emicet or ondansetron, as we say is a generic name, for very few conditions. However, in practical practice, it is generally given as a first line syrup. On that note, I thank you for listening to this presentation, and I thank IAP for ensuring that these slides are available. I'd like to mention that this presentation is targeted towards medical students and towards the medical fraternity. If you're a parent who is watching this presentation, please do not take the matter of calculating the syrup into your own hand based on the dosage what I have shown. It is always best to ensure your child is physically examined by a pediatrician before going for giving the medication, and ondansetron MSet is not an over-the-counter drug. If you have taken some amount of awareness from this presentation as a parent, you do ensure that first line management for your child, if the child has vomiting, is to ensure SIPs to ensure that the vomiting does not occur. And this presentation cannot replace the advice of a medical practitioner who has physically examined the child and has prescribed accordingly. Thank you once more for listening, and I hope you tune into the next video also.